Today we are going to see about a case scenario which is based on the subject Adult Health Nursing 1, and in this we are going to see about the cardiovascular disease. Let us go to the case scenario. So in this case scenario, I would like to explain the case how we saw or we witnessed in the emergency room. So Mr. X, male patient, aged 50 years, came with the chief complaints of chest pain which was radiating to his back and neck for the past 4 hours. And the patient moreover complained of breathlessness, dyspnea, profuse sweating for the past 3 hours. He was brought to the ER department, that is emergency room, in the ambulance, and upon further examination and history collection, he was a known case of diabetes type 2 and hypertension for the past 10 years, and he was on treatment with OHA as well as antihypertensive drugs. And on the past surgical history, appendectomy has been done for the past previously 4 years back, and it was done by laparotomy. And upon the social history, he was a known smoker and he was also a known junk food eater for the past 12 years. So the chest X-ray, ECG, cardiac biomarkers was taken, and which turned to be positive. And hence he was planned for primary angioplasty as he was diagnosed with double vessel disease with 50% block in the RCA and the circumflex artery. So let us see about this diagnosis, how to treat, how it is diagnosed, and what are the common clinical symptoms the patient will be pronounced, as well as we will be seeing about the possible management and rehabilitation. So coming to myocardial infarction. So this myocardial infarction, otherwise we call it as the heart attack, which is commonly attacking the coronary artery due to decreased blood flow to the coronary artery, which is causing the major changes. That is mostly you can see the patient is having, like here I am showing the pointer. So these are the coronary arteries which is branching from the root of aorta, and from the coronary sinus you can see that is the RCA and the LCA. So if there is any blockage in these arteries, the patient is going to have decreased blood supply to those myocardial tissues, ending up with stages of ischemia, injury, and as well as necrosis, which we'll be seeing in the further slides. And the most common symptom the patient complains of this condition is chest pain and discomfort, and which is classically radiating to the left shoulder as well as arm or the jaw. And the pain may be occasionally in certain patients, they will be describing it as a heartburn like pain. So the common causes of ischemia or non-ischemic causes would be majorly due to obstruction, as we earlier saw that any coronary artery getting occluded, or might be due to the spasm of the artery, or there is a moving embolism, that is either fat embolism or the blood placed and that clot is being moving from distant side, especially in case of DVT or any other disorder of the vascular chambers. And some patients may also with in case of atrial fibrillation or tachyarrhythmia or any sort of dysrhythmias, those patients are also high risk for developing myocardial infarction. And in case of severe anemia, already the RBC count is very low, which is not going to supply oxygenated blood to the tissues, thereby causing the necrosis of the myocardium. And might be due to hypotension, that is even when the flow of blood is very slow, and so thereby it is going to directly impact on the cardiac output, which causes a major changes on the coronary blood supply, as well as in times of shock. So shock is nothing but a condition where there is decreased blood supply to the tissues, which is the tissues are going for hypoxia, and thereby they are ending up with cardiac arrest. And in case of severe hypertension, which can cause any cause of bleeding inside the chambers of the heart, which causes this indirect impact to develop the myocardial infarction. The non-ischemic causes for MI would be heart failure, myocarditis, like all the symptoms and disorders which is relevant to the cardiac features, like patients with cardiomyopathy or stress syndrome, which we call it as Takotsubo syndrome. And in case of previously revascularization done, or previous cardiac surgery done, or previous catheter ablation done, those patients can also develop in the post uh, care when it is not given adequate care, and in case of cardiac contusion as well. Some of the non-cardiac causes for non-MIs like chronic kidney disease, pulmonary artery hypertension, amyloidosis, sarcoidosis, chemotherapy agents, infections, and sepsis, and so on. So in this picture, you can see that the age will be the major contributing factor to develop the vascular changes, which causes a direct impact on the heart, and hereditary, that is the genetic factor, which plays a major role. Lifestyle, sedentary lifestyle, which causes large deposition of the atherosclerotic plaques, and stress. So in case of severe stress, you can see the cortisol level elevated, which causes the cardiac output also disturbances. That way, it is affecting to develop the MI. And in case of obesity, diabetes patients who are consuming unhealthy foods such as mostly developing, you can see that all junk foods as well as alcoholism or smoking or not controlling the blood pressure. All these will be a major contributing factor to develop MI. So the risk factors we can divide in simple terms such as modifiable and non-modifiable risk factors. The modifiable risk factors will be high BP, smoking, diabetes mellitus, physical inactivity, obesity and high blood cholesterol. So why do we coin it as modifiable risk factors in the sense, if a patient is suffering with high BP, if the BP is controlled or kept within the control limits, then we can prevent this MI formation. Or if the patient is a known smoker, if we give some rehabilitation to recover himself from smoking, so those client also will be early prevention from MI. And diabetes, when the blood sugar levels are well controlled, then MI can be prevented. Physical inactivity, so in order to that, we can impact on the exercise, we can give advices or we can give health teaching relevant to exercise, what are the possible exercises the patient can do. That way the physical inactivity can also be removed from the risk factor. Obesity, so naturally if the patient is going on with physical activity, his deposition of central fat that is in the abdomen can be prevented. So that way indirectly obesity also can be controlled, and which also controls the blood cholesterol. Non-modifiable risk factor in the sense we cannot go and alter or we cannot do some intervention to change the risk factors such as age, old age are more predominant to develop MI, gender, mostly the male gender are being affected when compared to the female, genetic factors, so here genetic factor we cannot go and change the gene alteration, race and ethnicity. So coming to the pathophysiology of MI. So in MI we can see that the patient is developing this infarction due to either fat deposition, that is atherosclerosis, or might be due to arterial spasm, or it might be along with others such as atherosclerosis with plaque formation, and this plaque is being split and it is developing a thrombus. So all these factors will be contributing to obstruction or occlusion, eventually which obstructs the outflow, that is the blood flow, which causes ischemia. So when ischemia is nothing but reduced blood supply to the tissues and cells. So here where is the tissue? The myocardium. So the myocardium and the myocardial cells are now being deprived of oxygenated blood, which causes hypoxia. What is hypoxia? It is decreased oxygen in the blood. So prolonged time when the blood is having decreased oxygen content in the cells, which causes reduced oxygen demand. That is, patient is not having good oxygenated blood, which causes chest pain, that is angina, that is pectoral muscle pain. So which is not controlled if you are not giving any oxygen immediately. This condition may lead to the next step, which is thrombolysis, which is the thrombus is getting split up, and that is the moving clot moves, and finally you can see the myocardium sensor going for permanent necrosis. So how we can diagnose this MI? Yes, just by taking the blood samples and we can identify whether it is acute or chronic or it is an anginal pain. So the common biomarkers of myocardial infarction will be CPK-MB, that is creatinine phosphokinase membrane bound, myoglobin, troponin I, troponin T, and of course we will also go in for the lipid profiles as well. So here you can see in the x-axis they have given the hours and days, and in the y-axis the level how the enzymes are peaking up and then coming to normal plateau level, and it's coming into the dormant state. So in case when the patient is coming to our emergency room or ICU with chest pain and you take the blood sample and you find that the myoglobin is very peak, it shows that the patient is within 6 hours of golden time. So you can immediately plan in for angioplasty or might be primary angioplasty or CAG, might be placing a stent balloon stenting procedures can be planned. And in like with this changes, that is the peak level increasing and then it is declining and finally coming to dormant value. So with this we can compare whether the patient is having acute MI or chronic MI or it was an evolved MI, and we can plan for management. So the next is that to diagnose how the patient is having MI is that the hallmark so diagnostic intervention is that ECG. We all would have come across in emergency room or in an ICU. Whenever any client says that he is having chest pain, then immediately we plan in for an emergency ECG. So this is a 12-lead ECG where 4 leads are being placed onto the extremities, and you can see the chest leads are comprising of 6 leads. So here you have lead 1, 2, 3, AVR, AVL, AVF is augmented leads, followed by that from V1 to V6 is your chest leads. So in this there are another two more thing where it is shown up as P4R, V8 and V9, which is nothing but the posterior leads, which is being placed, the leads will be placed posterior to the left dorsum, that is left posterior aspects of the chest. So here the pink indicates the inferior MI, that is when you see there is an ST elevation, that is the S and the T segment getting elevated in lead 2, 3 and AVF, which shows that the patient is suffering from lateral wall MI, or might be patient is suffering with inferior wall MI. And in case if the patient is having ST elevation segment changes in lead 1, AVL, V5 and V6, which shows that the patient is having high lateral MI. And if the patient is having ST elevation in V1, V2, V3 and V4, this indicates that the patient is having anterior wall MI. And if the patient is going to have changes in V8 and V9, which shows that patient is having posterior wall MI. If there is an ST elevation in P4R, that is RV lead, which shows that the patient is having the right ventricular chambers being partially affected. So these anterior, lateral, posterior and anterior on shows that which portion of the heart is now not receiving blood supply. Might be you think that this is the heart. So in case the changes are showing in one AVL, V5 and V6, then that shows that the lateral wall of the part of the myocardium is not receiving blood supply, which is the side portion. Posterior portion means the backward portion of the heart, and if it is inferior, that is the above portion, and anterior it is the heart chambers which is in the front. So on this, which shows that which blood supply is not getting which artery is not being received blood supply, which causes the direct impact on the heart tissue. So we can also do an echocardiogram and find out what type of what is the ejection fraction of the patient, whether there is adequate LV, and accordingly we can plan for fluid administration as well. And we can also diagnose a patient by doing a nuclear muga scan, which is like directly the radioactive material is injected to the patient, and then we will be placing the patient on this table, and then series of pictures will be taken, and which shows that some of the sliced heart of the pictures shows that if there is no oxygenated blood, that can be demarked or marked very specifically in that particular area. So this is a mnemonic to give the therapy such as MONAD TAS. So MONAD M stands for morphine administration, O2 administration, nitroglycerin. So nitroglycerin is a vasodilator. We saw in the causes like maybe due to the vasospasm of the coronary artery causes the MI. So in order to improve that blood flow, we are going to give NTG, aspirin to remove the thrombus formation, and if it is a heavy thrombus, we have to plan for anticoagulant, thrombolytics, and to avoid straining at stone softness and sedatives can be given to the patient. These are the common drugs which is used in MI: antiplatelet agents, thrombolytics, nitrates, AC inhibitors, analgesics, vasodilators, beta blockers, anti-anxiety drugs, anticoagulants, anti-arrhythmic drugs if the patient is having any dysrhythmias. And if the patient is having a poor cardiac output, then we have to plan in for inotropic agents, especially positive inotropes, and miscellaneous drugs, that is the other drugs which is essentially given in case of any electrolyte imbalances. So these are the common examples of these pharmacological group of drugs. So the definitive management would be planning for a balloon angioplasty or a coronary and CABG, that is coronary artery bypass graft. So in this what they do is that they remove the block by suction, and then the stent is being a balloon is inserted, and it is the artery is inflamed. Once it is inflamed, we can see that the balloon is inflated, which expands the stent as well as the artery, and then the stent is placed inside and the balloon is removed. So coming to the rehabilitation session, lipid lowering agents can be planned, depression and anxiety counseling will be given, self-support counseling, group education sessions will be planned for these cases, and how to maintain the cholesterol level as well as blood sugar management will be explained to the client. Weight management, so exercises, therapies the patient will be going, dietary counseling to prevent the cardiac good cholesterol diet must be taken, bad cholesterol to be avoided, and so on. On-site exercises training will be given, exercise counseling will be given, smoking cessation and what is the importance of the cessation of smoking will be explained to the patient, as well as the glucose control and blood pressure management will be explained to the patient in rehabilitation. So by now I know that we would have come across of what are the possible managements of MI, how it is screened, and what are the techniques we do. So if you have any queries or doubts, please put onto the comment box, and don't forget to like and share. Thank you for your patient listening. Thank you.